So I think you have to put
Good
the
evening to
slide.
all. So I congratulate Dr. Nagaraj Desai and Dr. Ullas Pandrangi for their excellent talk in the last two sessions. So this last talk of this webinar is IHD in ECG, that is IHD in ECG. To present this, we have got a Dr. Prabhakar Koregol. At present, he is a senior consultant cardiologist working at Fortis Hospital, Bangalore, and he is a alumni of Mysore Medical College, and he did his MD General Medicine from MR Medical College and DM Cardiology from LT MMC, and he has got a lot of academic credentials in the national and international publications, and he is a resource person in the state and national and international conferences. I think though the ECG has been invented more than 1 century ago, still the ECG has got a lot of a pivotal role in the diagnosis of especially ischemic heart disease. Even with the advent of so many gadgets and biomarkers and other things, ECG is the one which plays a very important, crucial role as an initial workup of the ischemic heart disease. So there are so many issues, there are so many false positive, false negative, and ECG changes in IHD to consider for further treatment aspect and other thing. There are so many things are there. Dr. Prabhakar Koregol is going to talk on this. I request Dr. Prabhakar Koregol to go ahead with this talk. Thank you.
Thank you, sir, for that kind introduction. Thanking the chairperson, course directors, and the sponsors for giving me this opportunity, and thanking all attendees for their presence and patient hearing. Before I go into, as requested by Dr. Baswan Gowda, I would like to answer the question that was put in a box in between. He had requested for the answer. There was somebody asking a question of sensitivity of AVR elevation in left main stenosis. We have various studies differ as it is, but when you have an isolated AVR elevation with ST depression in multiple leads, the sensitivity is about 76 to 80%. Specificity is about 85%. But as a clinician, what you should know, apart from the sensitivity specificity, is about the negative predictive value and the positive predictive value, which are more important for me as a clinician. If you had all attended our biostatistics class, that would make lots of sense. It has a positive predictive value of only 57%. So if you have 100 ECGs, only 57 of them are likely to be a left main this thing. And if it is absent, negative predictive value is about 95%. That is where, of course, these have to be not an AVR ST elevations associated with other ECG abnormalities like RBBV. I think that answers the question, sir.
Thank you, Prabhakar. You can go ahead with your presentation.
Yes. So the topic that was given to me was commandments and caveats of ECG in ischemic heart disease. With the permission of chair, I would like to add 2 S's to that. I'd like to talk about ECGs in ischemic heart diseases. This is because the way we acquire our ECGs has changed. It's not just the one long strip of paper that used to come, and nor is a ischemic heart disease anymore has remained as a one single entity. So commandments and caveats, I thought of listing some 10 commandments and 10 caveats, but I could not zero down on that. But something to start. Commandment is, I'm going to talk something that is sensible and useful to the people who have blessed me with their presence and time. And I would like to have a commandment of finishing it in 30 minutes. My caveats would be, I'm not able to cover all the relevant points and may not be able to finish all my slides before course director stops me. So let's start off. Let's jump into the topic. As Professor Desai is mentioning some things related to this particular event, I would like to start my talk with this Jimmy. And as you would see, there are lots of discussions that are happening with the COVID. The more discussions go regarding how much bribe was paid or how much money was spent. Even when ECG was initially discovered and presented, the first discussion was regarding cruelty to this animal rather than the usefulness of the ECG. The American politicians spent all their time discussing about whether the animal was harmed and there was a cruelty rather than anybody talking about the ECG. That's basically because of the understanding was so naive at that stage about the ECGs. So what I'm going to talk about some basics, talk about some rare ECGs, talk something little local, or what I would say is a localizing of the ECG values. So let's start with a case. A 45-year-old premenopausal woman, not a known case of hypertension, diabetes, CAD, or peripheral vascular disease. No known significant family history, presents with us 12 hours of chest pain radiating to the back. Treated at a taluk place in Raichur district called Manvi. No relief of symptoms. Reports to my dear friend and Professor and Dean of RIMS, Dr. Basaraj Patil. We did our MD together. Patient is in pain at presentation. No major remarkable examination findings except for the pulse of 100 per minute and the BP of 180 by 100, which we generally see with anybody who has a severe pain. This ECG was taken by my friend and with a typical ongoing chest pain, which was severe radiating to the back with STT changes. Yes, you all would have already thought and made a diagnosis. Unstable angina, non-ST elevation, MI. And the treatment was started. All the standard care was provided, but patient did not have any relief of symptoms till the next day morning. So we considered the differential diagnosis and then decided to do a CT. And for those of you who can read the chest CTs, this is what we would find. Of course, I'll be showing you the report. You can just, for the interesting aspect of it, a tear in the aorta, can look at it. And we had a diagnosis of aortic dissection, which was well reported by the diagnostic center in Raichur, extensive aortic dissection and cardiomegaly with minimal pleural effusion. And this lady was fortunate enough to report to us and get a surgery done and survive despite of having an extensive type A stand foot and being in a taluk place. So this takes me to the next, though not very appropriate commandment for my talk. All chest pain with ECG changes is not ischemic heart disease, and caveats are many. We shall keep visiting it back and forth again. So why did I change this thing to the ischemic heart diseases? Because when somebody suddenly talks about an ischemic heart disease, you have an stable angina, you have congestive heart failure, you have unstable angina, variant angina, arrhythmia, silent ischemia, A syndrome X, and the acute MIs, which all needs to be addressed to. And I specifically said about ECGs because there is the ECG, which is commonly referred to as a 12-lead ECG. There's an exercise ECG. Then there is this ambulatory ECG and many more different format of acquiring the information. So going on to some basic facts, 12-lead ECG is the most frequent used diagnostic method in patients suspected of ischemic heart disease. Practically all patients presenting to the emergency room with chest pain or an ECG is recorded, and many times recorded in the ambulances. And an inducible ECG changes during exercise or the pharmacological stress are commonly used tests. Why? Because it provides a unique perspective of the condition of the heart just on a surface recording. It's an inexpensive examination with nearly zero risk to the patient, can be performed within few minutes, widely available, and medical community has a long experience with methods because it has been around for more than 100 years. This makes it a very useful, this thing. Currently, the standard of care is 12-lead ECG, and many of us are moving to the body surface mapping as well. But however, ECG is by far not as accurate as many patients and many physicians would like to believe. Often the finding of measurements are completely not even through the heart attack, not there even though the heart attack has taken place. As a result, ECG does not detect 2 out of every 3 ischemic heart disease, at all or not until it's almost too late. In order to minimize the secondary damage and risks of sudden death, every minute counts, especially when the patient is suffering from an acute heart. So from the point of view of interest of postgraduate students here, the one more important thing would be a pathophysiology of ischemia. It would suffice to remember that we are talking about phase 2 and phase 4 as an important aspects of changes in the ischemic myocardium, which produces all our ECG changes. So I would not go in depth into the ECG manifestation of ischemia, which you are all aware of. When I say ischemia, I am also generically including the infarction as well. So most common would be ST segment depression, ST segment elevation, alternance, intravascular conduction, ventricular conduction abnormalities, and D-wave inversions. So I would like to go on to certain specific aspects, though I will briefly touch upon the ST elevations and ST depression. How useful is a ECG? As during Dr. Vilas's speech, he did come upon and commented upon that infarction patient. Does the ECG predict the severity of CAD or the ischemia? More preferably talking about ischemia. If you have an acute MI, the amplitude of acute ischemic ST elevation indicates the severity of ischemia. If marked ST elevations at the depression, multiple leads are observed, consider severe ischemia or ischemic effect, large region of the myocardium. Note these observations are not universal, saying that when you have a significant ECG changes, yes, we have a significant disease. But whereas the people with minimal or slight ST changes can have still a very significant disease. So that would be taken as a command or the caveat based on your clinical situation. So when we talk about ST elevations, you are all aware of the criteria. A new ST elevation at J point, which is more than 1 millivolt or 1 small square in the chest leads, are about 2 millimeter in the, 1 millivolt in the chest leads and the 2 millivolts in the chest leads. So what I would like you to focus about, apart from that 1 millimeter, 2 millimeter measurement and the contiguous leads, is depending upon how quickly a patient comes, you can have a different ECG ST elevations. You can see this A, which is essentially a normal ECG. The patient comes to you very early, especially less than 90 minutes, sometimes even up to 3 hours, you can have a normal ECG or very slight changes. Then a minimal ST elevations come, and then there'll be a tall and rounded T waves, where subsequently ST elevations go on to become what is shown in C. And as and when time passes, even without treatment or with treatment, the ST depressions can come down and the T waves start inverting. And eventually, we'll have only T wave inversions without any this. And at the end of the couple of months or years, few of the patients with MI can have a completely normal ECG. So depending upon the time frame, the ECG changes, the magnitude of the ECG changes. So ECG segment morphology, this is always spoken about, concave, non-convex, and convex. So convex ECGs are supposed to be more suggestive of STEMI typically, but concave or non-ischemic are related to pericarditis and such of the etiologies. But then in an appropriate situation, the morphology of ST elevation may not be very, very relevant. ST depression and T wave changes. Again, I'll skip this theory slide and come to the morphology. We essentially have 3 types of ST depressions. One is what is shown in the first slide, the upsloping ST depressions. These are very, very frequent ST depressions, but they do not really talk about the ischemia as a cause, and many, many false positive tests. And especially during the exercise testing, lots of patients develop this kind of ST depressions, which may be misinterpreted as a ischemic ST depressions. Whereas when we have a horizontal ST depressions, as shown in the second picture, it's almost always associated with the ischemia as a cause. If it's a downsloping, the certainty of association becomes more frequent. So close your eyes, look at the ST depressions, look at its morphology, look at its depth. It will tell you whether it's ischemic or no, and whether it's severe ischemia or no. T waves are very variable in ischemic heart disease. It can be flat, it can be T wave inversions, it can be scooping of T waves, and in a very early phase of ischemia, we can have a tall T waves. So when we talk about the STT changes, the commands would be in a given clinical scenario, typical changes in the typical clinical scenario, changes are diagnostic of ischemic heart disease. Caveat is there are many causes of STT changes that are more likely to be non-ischemic than ischemic, even in the presence of typical change in the absence of clinical scenario. So again, stressing what Professor Desai and Dr. Ullas were speaking, it's a clinical scenario that matters. If you have a patient who has a typical clinical scenario of ischemic heart disease, harp upon diagnosing despite of having a normal ECG. But if you are not clinically thinking of ischemic heart disease, then don't take every T waves and start investigating for the ischemic heart disease. So just to list few of the causes and the morphologies, you can have STT changes in LVH, you can have it in WPW syndrome, in right ventricular hypertrophy, people on digitalis, people with subarachnoid hemorrhage, then in LBBB, RBBB, and the ischemia. If you take all the people who have ECG changes, the people with ischemic heart disease would be constituting a lesser percentage. So after having spoken, so actually at this my talk on ECG changes would be sort of coming to an end because we have spoken about STT changes and that's all we speak about. But there are ECG changes that are not typical of above description but give more definitive information. And these are quite useful data for the postgraduates also because these are asked pretty commonly and frequently in the ECGs. So the examination, sorry. So command is atypical signs of typical syndrome, but my caveat would be do not overinterpret these patterns that I'm going to discuss in the absence of typical clinical scenarios. So Valence syndrome, we are not talking about the neurology here, I'm in cardiologist. So this is one thing what we talk about as a LAD T wave inversion syndrome. Many a times we think there are changes, but then we tend to neglect in the absence of ST elevations, but they are presenting of a very ominous sign. First described in 1982, there are type A and type B valence. Essentially, these people will have a T wave inversions that are biphasic in the precordial leads V2 and V3. And some of them are quite deep and obvious, but more common that second pattern type B is very less specific, easier to recognize and characterize by the type B is easier to recognize, whereas type A is not very easy to detect because the ECG changes are subtle. In fact, one of the ECGs Professor Desai was talking about as a normal, if it had a biphasic T wave, we would have thought in terms of the valence. This is how it would look at. If you look at this ECG, many times some of us do miss this thing to an artifact or something because all the other part of ECG essentially looks to be normal. You can see this arrow marks here which shows the biphasic T waves. Of course, if these become tall and this is deep, then you would have easily picked it up. So valence type A is an important ECG which we keep missing, especially if the patient has chest pain, give lots of importance because the next thing you will see will be a large anterior infarct in these people. There's something called D Winter ST T wave complex. We used to have a professor who used to say that ST elevation is not the only reason to thrombolize the patient. And at that time, we all thought like, no, how can this be? All guidelines tell us that ST elevation is a must to do a thrombolysis. Even today that stands. But then what we want to stress here is there are sometimes scenarios where there are MIs, but there are no ST elevation. One such thing is a D Winter ST T wave complex. It's a rare special electrocardiographic manifestation where the people have a total or subtotal occlusion of the proximal LAD. I'll show one of our cases. It may appear as an ST segment oblique depression instead of ST elevations. So this is what is a ECG. Look at the first focus on the downside. You can see that there are ST depressions in V1, V2, V3, V4, which is an oblique ST depression. It's not a typical downsloping depression that you saw in the other pattern that I described. but an oblique ST depression. And when we do the angiogram for these people, this is what we find. This LAD is totally occluded here, RCS, some minor disease, circumflex looks fine. And when this some more time is given, the ECG tend to be emerging like this. And post PCI, the ECG normalizes. So this is a textbook illustration of the same phenomenon. So those are about the rare signs. But then the next thing that comes with any ischemic heart disease, this thing is whenever I talk and teach general practitioners this one, I always tell them if you see an ST elevations, just focus on ST elevations, but don't bother about the ST depressions. But for an academician and for the clinician treating the MIs, ischemia at distance versus reciprocal changes becomes important. Patients with ST elevation in one territory often have a ST depression in other territories. You would have all seen this. And additional ST deviation may represent an acute ischemia due to the coronary artery disease in a non-infarct related arteries, or may manifest as a pure mirror image of reciprocal changes. Most common pattern of remote ST depression probably represents reciprocal change and does not represent an ischemia at distance. But there are many people whom we do an angiogram and we see a triple cell disease being there. So in the interest of time, I would skip the details of this reciprocal change, but I would talk about just about the inferior wall MI. In patients with ST inferior wall MI, ST depression in AVL is a pure reciprocal change and is found in almost all patients. And ST depression in V1, V3 probably do not represent the ischemia at distance, but rather a reciprocal change. But if such a patient has an ST depression in V4 to V6, the associated concomitant LAD disease should be thought. And in the presence of atypical patterns of ST depressions, and especially ST depressions in V4 to V6, inferior wall MI generally suggests the ischemia at distance. So that is, I hope you are catching up with here. Whenever the patient has an MI, we can look at the other side, which looks at the ST depression without an additional region being involved. But when I talk about the ischemia at distance, we are talking about one more artery being the reason for that disease. So in some circumstances, both types of ST depression may be present. In acute myocardial infarction due to the acute D1, for example, the reciprocal ST depression is associated with the negative T waves. In contrast, if the type of myocardial infarction, if there is a ST depression in V3 to V5, it signifies the subendocardial. This type of ST depression is associated with the tall T waves. When I come to the, sorry, I missed that representation there. So next, this thing is, whenever you have a patient with an ischemic heart disease coming with an ST elevation myocardial infarction, they can have ST depressions and T wave inversions in the leads that are outside the purview of your diagnosis. For example, an inferior wall infarct, having STT changes outside the 2-3 AVF, we'll have to be knowing whether the patient has an additional artery disease or it is only a one vessel involvement, because that has a diagnostic, prognostic, and therapeutic value. Similarly, after having spoken to this, the last point I would like to touch upon would be about ECG as a localizing. We are all taught there's an ECG, there are 12 leads. You look at certain combination of leads and you call them as a inferior wall MI, inferior lateral MI, inferior posterior MI, anterior wall MI, anteroseptal MI, extensive anterior wall MI, certain things which we do our own descriptive diagnosis. But as a clinician and as an interventionist, will ECG help me to decide what artery I am going to be treating? And many times it's very, very easy to say that, look, why bother about it? Let's go in and scout it and see. That's what we as an interventional cardiologist would like to see. But many a times, especially in an acute coronary syndrome, we have gone in, done an angiogram. We want to treat a lesion that is causing the patient symptom and the patient instability. We wouldn't decide on the angiogram. We get back to the ECG and have a look at the ECG thoroughly and then decide, yes, which is the vessel which I need to tackle, especially when it is not a straightforward simple vessel, single vessel disease. So for that, I will touch upon what is called as a localization based on the ECG. Many times thought to be a domain of angiography, but we all fall back on the ECG because of its own prognostic implication, crucial value not only from the academic standpoint, but from the therapeutic treatment, especially interventional. We need to be very, very sure which artery is producing the particular changes. I will again start with the, and if after the recent, there's lots of data which comes when you have an MI, you should treat only a infarct related vessel and not all the other vessels in the index event. In that, we always are faced with a problem when we have an acute inferior myocardial infarction, whether it is due to the right coronary artery or the left circumflex artery. Because fortunately, LAD causes and majority of the times interval MI, and we don't have too much of an ambiguity there. And also when you have an RC occlusion or LCX occlusion, you need to know whether it's proximal, distal, dominant RC occlusion or non-dominant RC occlusion. Circumflex, again, we talk about whether we have a proximal distal circumflex occlusion or only a OM occlusion. Because especially in the era of COVID, if you have a small infarct, you may be able to say, I am going to do a medical management, lysis is good enough. Whereas if I have a proximal vessel involvement, I would like to do a interventional therapy. So when you have an ECG with an inferior wall MI, we need to know whether we have an RCA or the LCX as a culprit. So certain points which I'll come back to a flow chart, but then ST elevation in lead 3 more than 2 almost always tells us like we are looking at an RCA as a culprit vessel. If you have a ST depression in AVL, ST depression in lead 1 with ST depression more than 1 millimeter in lead 1 and AVL, then we are again looking at RCA. RVMI by and large suggests, as suggested by V3R and V4R, suggest an RCA as a culprit vessel. Ratio of ST depression in V3 to ST elevation in lead 3 of more than less than 0.5 again points towards the RCA. Decrease amplitude and increase in the S wave amplitude and SR ratio of more than 3 in the AVL. So this is a typical ECG. You have a lead 3 ST elevation, which is more than lead 2 ST elevations. Then you have ST depression in V1, V2, V3. And the other ratios, if you can calculate, they also define to the what we spoke about. The ECG of the same, this thing of with the diagrams and the background. So what will tell you you have an RCA infarct, ST elevation in lead 3 more than lead 2, ST depression in lead 1 and AVL are both, and ST deviation in AVL more than lead 1, and ST elevations in V1 or V4R are both, is something that tells you it's a RCA infarct. Again, and whether it's a proximal or distal is decided by whether if there's a right ventricular myocardial infarction, we are likely to be looking at the RC occlusion proximally, and ratio of ST depression in V3 to ST elevation in V3, if it's less than 0.5, again we are looking at proximal RCA involvement. Mid and distal RCA if they do not follow the what we spoke in the previous slide. So what will suggest LCX occlusion? It's not as straightforward as what we spoke about RCA. ST segment elevation in lead 3 is not greater than that in the lead 2 is suggestive of LCX occlusion. But for the person who put the question that I answered in the beginning, if we'll start looking at the sensitivity, specificity, and predictive values, this is not a great sign. And reciprocal ST depression in V1 and V2, suggestive of post-oval MI, also tells us that it's a LCX occlusion. No RV injury to that is what gives us this post-oval. ST elevations in V4 to V6 also tells us that we are likely to be looking at circumflex. So this is a circumflex infarct. You can see that the lead 2 ST elevations are much higher than the what we see in the lead 3. And then we have a ST elevations in V5, V6 with ST depressions in V1, V2, V3. So this sudden transition of the depressions to the ST elevation is also a good pointer to tell us that it's not an additional infarct, it's a part of inferior valve. So right ventricular myocardial infarction, touching it because it's not, it's one of the stock questions and not daily discussed when we talk about the MIs. It generally occurs in the occlusion of the proximal RCA and it's identified by ST elevation in V1 in association with inferior wall MI. We generally don't make an isolated RV infarct diagnosis, except as certain very rare conditions. ST elevation more than 1 millimeter in V4R with upright T waves, QS or QR in V3R and the V4R. Occasionally, ST segment elevation in V2, V3 also may be suggestive of RV infarct, which many a times we tend to make a diagnosis of a simultaneous RV and LV infarct, I mean inferior and anterior infarct. So this is how would an proximal RCA infarct with a RV infarct would look, and dysplasia occlusion without an RV infarct, and the LCF occlusion is how a V1 would look, just to differentiate between the three formats in the people with 2-3 AVF ST elevations. Look at this. This is a situation where we as a MBBS students would have started talking. This fellow has a inferior wall MI and also has an anterior wall MI because he has a V1, V2, V3 ST elevations. But then looking at the magnitude, looking at the format, and again, this much of magnitude of V1 ST elevation is rare in anterior wall MI. We would like to call this as an RV infarct, which of course echocardiography would clarify easily. Posterior wall infarct has its own criteria. ST segment elevation in the posterior leads, if you are taking an additional leads like V7, V6, V8, V9 of more than 0.5 millimeter, along with an inferior wall MI, will tell us there's a posterior. But how do we look for the posterior wall MI in the 12 lead ECG? ST segment depression in lead V1 and V2. In case of inferior wall MI, suggests that there is a posterior wall MI. And abnormal R in V1, that is the 0.04 in duration, and RS ratio of more than 1 in the absence of pre-excitation or right ventricular hypertrophy also tells us that there's a posterior wall MI with inferior or lateral Q waves. Isolated occlusion of dominant circumflex without collateral circulation can be decided. So these are the 3 points that tell us to look for when we are looking at the posterior wall MI. Isolated ST elevations in V5, V7 to V9 in the place where we routinely take a 15 lead ECG can occur in about 4% of the patients with acute myocardial infarction, and usually again suggestive of a left circumflex coronary artery occlusion. These are the people who only present as ST depression in your routine 12 lead ECG, but if you take the V7 to V6, V7 to V9, you will get the ST elevations, and they qualify for calling as a STEMI rather than NSTEMI. So my localization would be this all we have already looked for. V4R, if V4R, then look for the ST elevation in lead V1, lead 1. Elevation is there, circumflex is there. If it's the isoelectric, then look at the lead 2 and 3. If lead 2 is more than 3, then it suggests of the circumflex. If lead 3 is more than lead 2, that's a ST elevation, then it's suggestive of a RCA occlusion. If there's a ST depression in lead 1 or AVR, then RCA infarctism. And if the lead V4R is there, we already spoken about it and shown that picture. There are multiple criteria like Kosuga criteria. You can look at it if you are interested into it, which is more or less a different combination of what we spoke about. That is V3 to lead 3 ratio of ST depression, or that is the ST depression in V3 and ST elevation in lead 3. If you took a look at a ratio, if it's less than 0.5, we are talking about the proximal RCA. 0.5 to 1.2, we are looking at the distal RCA, and more than 1.2, we are looking at the circumflex infarcts. There are other things also like false algorithms or Taylor's algorithms, which have both are about 94% sensitive and 40% specific for RCA, and 40% sensitive and 94% specific for circumflex. So look at that number jargon there, false algorithm. So we are more learned about the RCA related infarct than the circumflex infarct. And whenever we have an anterior infarct, it's always in the LAD, but then differentiating whether it's proximal to the septal one or the diagonal one, or after that, or in between that, has a clinical implications, because the proximal to the S1 and D1 is one MI which has a maximum amount of mortality and morbidity, and also the complications like complete heart blocks in the anterior wall. Whereas when you go down into the occlusion, distal and distal, the prognosis tend to be better. So you have an ST elevation in V1 or V2. It starts many times V1 may not show the ST elevation to V5, V6. Then we know that it's a LED occlusion. Then check for STs in 2, 3 AVF. If the ST depression in lead 3 plus AVF is more than 2.5 millimeter, that is about 25 small squares, then occlusion of the proximal to the diagonal. If there's a new onset RBBB or ST elevations in AVR plus V1 plus ST depression more than V6 more than or equal to 0, then occlusion is proximal to septal 1. And SC isoelectric are elevated in 2, 3 AVF, occlusion is distal to D1. So we are able to differentiate 3 levels of occlusion in LAD, and it has its own different sensitivity, specificity, and predictive value. These are not the commandments, these are more of a caveats. So coming to the what we started initially, LMC stenosis, this becomes very, very important because these are the people who are fine, who are talking to you and suddenly collapse, and we may not even be able to resuscitate them. Typical finding in a severe LMC stenosis or occlusion include ST segment elevation in lead AVR more than V1 with the widespread ST depressions. When I say widespread, we generally talk about more than 8 leads of the 12 or anterior ST elevations. So this was what I was talking about, of course, but what I told is what is the average of multiple studies. This particular study says about these are present in 88% of the LMC obstruction group with 46% in LAD artery. So this is how LMC stenosis ECG would look. Of course, the ECG would look like similar in what we call as LMCA equivalent, where the people have a severe disease in LAD and LCX without the total occlusion. This is a AVR elevation here with multiple leads of ST depression, 1, 2, AVF, AVL, V2 onwards till about V6, so multiple lead ST depression. So this way we can localize what are the arteries. So ECG, apart from what we typically know, can have a different manifestations which give more information than just diagnosing there is a ECG, ischemic heart disease. The ECG per se will give you lots of angiography like data. ECG will give you a data which will tell what happens to the patient in next 5 years and 10 years. Arrhythmias, we heard from Dr. Ulas about arrhythmia, and as a cardiologist, I am yet to come across any arrhythmia that doesn't occur in an ischemic heart disease. There's no arrhythmia which I can say will never occur in ischemic heart disease, but it's outside the scope of this lecture. And suffices to say that the ischemic heart disease causes every possible tachy and brady arrhythmias, and the concept of ischemia-dependent conflictogenic arrhythmia. This is an important concept for those who are interested in knowing the role of ischemia. Not only, it doesn't only talk about the arrhythmia in ischemic heart disease, but ischemia is cause for the arrhythmias in other diseases like cardiomyopathies and channelopathies. So you can always read on this, and you can contact me personally to know the reference for this. So final commandments and caveats will be, ECG is a part of evaluation of every patient suspected of IHD, irrespective of whether you believe its value or no. Characteristic of ECG in an appropriate clinical picture is sufficient for a complete diagnosis in many cases, especially in the ST elevations. One ECG when non-diagnostics is not sufficient to rule out or rule in IHD, but serial ECGs can add on the values. ECG can be guided to further evaluation for the suspected IHD. And in a clinical ACS, there's a good chance to err on the overdiagnosis or underdiagnosis based on the your own assumption of the diagnosis based on the ECG. But my personal view would be, after a careful evaluation, err on overdiagnosing the STEMIs because any misdiagnosis is fatal in them, and underdiagnose and further evaluate other non-ST elevations and the unstable anginas, because over-aggressive treatment in these people can lead on to major catastrophes, which all of us have faced, including the intracranial blades or the complications of the catheterization. So how can we get better? One is about what we call as a cardiac infarction injury score. This is to improve our value of diagnosing. 24 hours ambulatory ECG monitoring, cardiogoniometry, and concepts like transparent heart. These are upcoming, but not yet very common in the clinical usage, the cardiogoniometry and the transparent heart. Thanks. And we are probably moving from a 12-lead ECG to this kind of an Alexander's shield kind of a shield where we take the ECGs and do what is called as a 3D activation sequence. More of Dr. Pandurangi's domain than ours at this stage. Thank you, sir. Over to the chair.
Thank you, Prabhakar, for an excellent presentation. You have told all about possible ECG changes that you could see in the spectrum of ischemic heart disease. Also, you have mentioned about how to go about localizing the culprit vessel. Now I leave it to Dr. Subhash to make a quick comment, and then we'll take up a few questions which are there.
I congratulate and thank Dr. Koregol, Dr. Prabhakar Koregol for his excellent presentation. He has highlighted what are the fallacies of record when you interpret in the ECG for IHD, and also over-diagnosing the IHD and acute myocardial, what are the consequences. I thank him for his excellent presentation in a short time. In a crisp manner, he has presented it very well. I thank once again and congratulate him. Thank you, sir.
Thank you, sir.
Thank you, Subhash. I think I have one quick question to Dr. Nagaraj Desai. There was the first question that appeared on the screen. Was P wave inversion. Is it normal or abnormal? Inverted P waves.
Oh, P wave. P wave inversion in, AVR.
Apart from AVR.
Yeah, in AVR, it is normal. V1, it can be seen occasionally. The vector of the P wave is always positive. If 2, 3 and AVF is flatter, then it indicates a change in the vector. If the P wave is inverted in V4, V5, V6, again it talks of abnormal P vector. So in other words, the P vector, when you examine it, is always 1, 2, 3. It is always positive. If it is a flatter P in 2 and 3 and AVF, it is an abnormal P. It may be electrical, or it may be something to do with even congenital heart disease sometimes.
Thank you, Desai. And we have a question to Dr. Ullas from Rajiv Dhawan, who had asked a question on sensitivity of ST elevation isolated in AVR. Now he has also another question: how to differentiate AVNRT from DAVNNT?
I would like to know the name of the person again, please.
Rajiv Dhawan.
He has to be sent to my EP lab.
Okay.
See, you need to have some degree of knowledge to ask questions. And he has not been one of the panelists or the speakers today.
Okay.
It takes courage to ask this question. So let's congratulate him. And I'm going to give him an invitation to visit my place, because this is truly, such an intellectual question, is an electrophysiological question. Let's talk about AV and RT. Many people, I think, in the audience have some difficulty to understand what is AV and RT. Well, it is atrioventricular nodal reentrant tachycardia. Now, our gentleman is asking us to differentiate it from DAVNNT. Wow. It is not really very much discussed because it's extremely rare. Now, what is that DAVNNT? That is dual atrioventricular nodal non-reentrant tachycardia. It's a wonderful is an arrhythmia. But then the gentleman should know, when the AVNRT is diagnosed on the basis of something which is absent on the narrow QRS tachycardia, and that is the P wave is not seen, okay, during an AVNRT. So it is the absence of the P wave is making AVNRT as a differential diagnosis. But it is the presence of the P wave is making this DAVNNT as the diagnosis. It is a P wave which gives rise to 2 QRS. It's a very unusual, but it is a rare cause of tachycardia. A P wave causes 2 QRS. Once it goes down, the fast pathway inscribes a QRS. The same P wave, if the slow pathway is real slow, it would find the ventricle non-refractory and causes another QRS. Those QRSs are narrow, but the rate, 1P, so if the person has got 60 beats per minute, he has a tachycardia, it's 120. If he is 100, then he will have 200. But the point here is the P waves are seen and the RR, even though it is the narrow QRS, it's not as regular. This is the question probably to test me. It's okay.
Rajiv Dhawan is
test me, but you know what? This is good that you've got an audience here. There's an audience here to stimulate the speakers. That's fantastic.
Thank you so much, Ullas. Rajiv Dhawan will definitely come and visit you. Then we have a question from Dr. Mahesh has commented. In the first case which you told, the young lady who came with chest pain and ECG tachycardia, you said splashing the ice water would produce a risk of aspiration. Would it not be better to put ice pack than ice water?
You know what, I got to get to see, when you splash, how can they aspirate, right? They can't. See, the element of startle.
This question is asked by Dr. Mahesh. He is a professor of medicine from JS.
Right. Splashing doesn't cause, is the droning, will cause aspiration. Splashing should not cause aspiration. But the point here is a good question. When you say splash, you are not telling the girl that you are going to splash, by the way. You are startling. you are startling the person. That fear, it is paradoxically is a vagomimetic. You splash a cold water on the face, it does not definitely cause the aspiration, but you should not say that now I will splash. Okay, don't prepare. You just bring it in. Then when you're putting an ice pack, you see that is very unlikely to revert this, because ice pack will also take some time. Okay, to create the effect. She gets acclimatized for the ice pack on the face. So that
it may not have the similar effect.
So that's not.
Thank you, Ullas. One question from Shantilal. He's asking how many episodes of SVT should be there before we, as an indication for EP study, and how common is posterior fiber involvement in the aberrancy?
Yeah. So the first part, how many episodes? You see, in general, if there are more episodes, if the patient is, is getting sick of those episodes, well, definitely that becomes a strong indication for an RFA. But if you're talking about an SVT, and if that SVT is in a structurally normal heart, even if it is a single episode, well, you may have to be telling the person that you may require an RFA even for that one episode. So for example, what was that? This person had an SVT and then patient had a syncopal episode. Well, you cannot make the person now to continue with some reassurance or a medication. It is the presentation is also very important. So more frequent episodes on drugs, I think it's a standard indication. One single episode, it is not an indication unless patient had a history of a syncope, is unexplained, and then this time she had come with the palpitations. I think it is better to consider that syncope is also because of this, and then make a stronger recommendation. But a person who comes every time with palpitations walking in because you had reassured, and he is very comfortable. Doctor, I don't want to take drugs. I don't want to come to your lab. I don't want to spend money. You have told me it is not going to cause death. It is not going to cause any problem. Doctor, you have told me to put 2 fingers into my mouth. I induce vomiting. I'm doing fine. So he comes here, he has fun, and he is willing to get an injection. And then if a junior doctor says, stay back, he says, Dr. Ullas had told, don't have to stay here. Get an injection and go. Well, he has got hundreds of episodes. This is not an indication now. So I think the symptom rather than the frequency should drive the recommendation for RFI.
Thank you, Ullas. I think we are overshooting the time. I have two questions quickly to one to you, and that is from Dr. Dr. Hussain, Sadat Hussain, who has asked a question about, again, Chawla has asked a question about a patient has come with recurrent palpitation, ECG, so only ventricular bigeminy. How do you go ahead?
Yeah, right. So same thing, which we did not cover. A ventricular bigeminy in a structural normal heart. Well, if it is minimally symptomatic, there's no need to do anything. Just a follow-up once in 6 months, once in a year with echocardiogram. But if that is associated with a structurally abnormal heart with some kind of a ventricular dysfunction, or over a period of follow-up, some degree of reduction in ejection fraction, or some other associated comorbidities, and some episodes of syncope, if at all, I think we should consider. But with the minimal symptoms of ventricular bigeminy,
Only
normal heart with minimal symptoms, ventricular bigeminy, normal heart, I think reassurance serves much more, purpose. Drugs don't work here. It is just an eye wash.
Thank you, Ullas. We have two very quick questions to Dr. Prabhakar Koregol. If you are going to miss 2 out of 3 ECGs, MI in ECG, then how are you going to pick up those 2 whom we are missing? This is a question asked by Dr. Suresh KS. Dr. Prabhakar, you have to unmute yourself. Yeah.
Sorry. First of all, let me clarify. We are that 2 out of 3 was not for the MIs. It was for the overall ischemic heart diseases. Of course, even when you have an MI, about 11% of the people are known to present with a completely normal-looking ECG at the initial presentation, especially when they come very early. The only answer for that would be to do a serial ECG, and not after 6 hours or 4 hours, something like that. Every 10 to 15 minutes, repeat the ECG. Of course, in today's world, many times, like we go in and take them for the angiogram if they have a typical symptoms and ongoing ischemic.
So only about initial ECG, not all ECG. Then another question from Srikant Rao. He says, what is the exact correlation in localizing culprit vessel between ECG, echo, and angio?
It depends on what we are looking at. And if we are talking about a proximal RCA, we have got nearly about 90% correlations. Whereas if we are looking at circumflex, our correlations are in the range of 60 to 70%. So on average, it would be about 70 to 75%. That's what I would put in.
In this COVID era, one should also remember to use echocardiography as a guide, simply because the echocardiographic left ventricular wall motion abnormality will be global and beyond the changes in the ECG that one sees. So it is very useful to understand the correlations. Good.
Thank you so much. I think with that, we come to an end of this webinar. I'm very, very thankful to Dr. Desai for designing this program. I'm hopeful we will have one more session on bradyarrhythmias and the metabolic disorders and ECG changes, if possible, sometime in the near future. I'll seek the time from Ullas and Prabhakar for their time for the next maybe a fortnight later, if possible. I'm very thankful to Desai. I'm thankful to Ullas for an excellent 4 ECGs. He took us through 45 minutes and very nice lesson through the ECGs. And Dr. Prabhakar has done an excellent job in a crystal clear presentation on how ECG changes can be variable between the individuals in a different case scenario in ECG, ischemic heart disease. And thankful to co-chair person, Dr. Subhash Chandra. And most importantly, we thank the Micro Labs, Corsian division for creating this platform and bringing in so many people who joined to this webinar. I'm sure many people who joined would have learned a lot of points through this webinar. I'm very thankful to each one of you. Thank you all.